Section 8 will cover endocrine pharmacology. We'll start with Chapter 1, the drugs used in diabetes, a very important chapter. And as we look at diabetes, remember that probably upwards of 10 million Americans are affected by the disease diabetes. And diabetes is classically divided in two types, although we know we refine this a little bit better nowadays. But type 1 is the juvenile onset insulin dependent diabetes, whereas type 2 is the non-insulin dependent diabetes, the one that is more adult in onset. In the type 1, we have an autoimmune destruction of beta cells of the pancreas, probably secondary to a viral infection, maybe to a Coxsackie virus. It seems that T cells play a key role in that destruction, hence the idea that possibly a type 4 hypersensitivity has resulted in that damage. Because of the loss of pancreatic beta cell, there is an absolute dependence on insulin for a type 1 diabetic. This is also the diabetic who will basically spend their metabolic picture in the glucagon world, never having insulin, and as such they will produce often ketones beyond their capacity to use them, so that they are prone to ketoacidosis. In a type 2 diabetes, often in the history there is an issue with being overweight, and progressively, in spite of generally adequate levels of insulin, a decreased response to this insulin. It has been long associated with an issue with the receptors to insulin, and rather than a receptor change in number, it seems to be in the signal transduction of these receptors that there is a disconnect somewhere, so that insulin no longer gives its responses to cells. This is not a diabetic who is really ketoacidosis prone until very late in the disease. It is rather a diabetic who could develop hyperosmolar coma from the high levels of glucose they can achieve in the blood. They will not respond to insulin. Therefore, to these diabetics, we're going to need to use oral hypoglycemiant or euglycemiant drugs that basically are not going to be the insulin molecule itself. Well, first, let's imagine what could be in pharmacology about insulin. And don't forget, really, most insulin questions you'll encounter the day of your boards will have to do with the biochemistry and the regulation of carbohydrate and lipid metabolism. But as far as using insulin as a drug, there are different forms of insulin, basically with Lispro and regular being the only forms that can be used IV because they are solutions. And as solutions of insulin, you would expect them to have a rapid onset within minutes, literally. Peak action is in 2 to 4 minutes IV. If it was used subcutaneously, it would take potentially half an hour to have an onset. And then literally within about 3-4 hours or so, it would go away. Don't learn these numbers as if they were etched in stone. You know, it will depend on the patient, his or her size, what they've eaten, what time of day they're using the insulin. The idea is for the patient to literally learn how to titrate himself or herself with the insulin. Nonetheless, only Lispro and regular can be used IV. All the other insulins are going to be suspension. Before we leave this IV insulin, here is glargine. Glargine is an insulin analog which has no peak. As a peakless insulin, the idea is to administer this glargine and have a background level of insulin with no risk of hypoglycemia due to the fact that there is no peak. So look, its duration is greater than 24 hours. In physiology, insulin is always present in our blood. It is true that there are spikes of insulin after each meals, but even in between meals, insulin is present. As a matter of fact, hormones such as glucagon, such as epinephrine, can actually trigger some insulin release. And the whole idea is we always need some presence of insulin, even at low level, to allow a proper glucose uptake by certain tissue, such as adipocyte, fast twitch skeletal muscle, and also simply to run the carbohydrate degradation in key tissues. Glargine, as an insulin with no peak, is used to supply a constant background level, as we said, looking at the table. But overall, how does insulin work? Insulin, if you remember your biochemistry, binds to membrane receptors which are not G-protein linked. They belong to the family of tyrosine kinase coupled receptors, just like growth factor receptors. That tyrosine kinase activity first autophosphorylate the receptor, then allows the binding of IRS1, if you recall your biochemistry, which then itself gets phosphorylated, then allowing the binding of SH2 domain proteins, which once themselves phosphorylated result in all kinds of changes in enzyme activity, with particularly the activation of phosphatases, so that enzymes that are rate limiting in pathways are generally dephosphorylated by the presence of insulin to be either turned on or turned off, and also some changes in gene expression. Some famous genes that are induced by insulin, for example, involve genes such as lipoprotein lipase, such as fatty acid synthase, such as glucokinase in the liver and beta cells of the pancreas. So I'm referring you here to your biochem, and don't underestimate, of course, your metabolic section of biochemistry. In your clinical correlate, there are words about ketoacidosis, a catastrophic event that will plague type 1 diabetic. Ketones are compounds such as beta-hydroxybutyrate, acetoacetate, and obviously also acetone. Acetone is not useful to deliver energy, being that it's too volatile. It is breathed out, and it is the acetone that is responsible for the fruity breath of someone with ketoacidosis. But beta-hydroxybutyrate and acetoacetate, these are forms of energy that are produced by the patient's liver when there is excess ATP from burning fat in the attempt to deliver to extrahepatic tissue a source of ATP also. Beta-hydroxybutyrate can give rise to NADH and 2-acetyl-CoAs. It's going to be used primarily by muscle tissue, such as heart muscle, by renal cortex, and if it was to be used by the brain, never forget it would only be in period of prolonged starvation. Acetoacetate, on the other hand, is going to give simply 2-acetyl-coenzyme A to extrahepatic tissue. Whatever the case may be, it is our liver at work in order to give food to extrahepatic tissue. Unfortunately, if we don't use those rapidly, they will build up. And you see the ends in 8, it means it is beta-hydroxybutyric acid and acetoacetic acid. Hence, the acidosis when those compounds build up. Symptoms are those of polyuria and polydipsia. As we filter those through our glomerulus and they get in the tubule, they increase osmolarity and therefore cause increased diuresis, nausea and fatigue from the acidosis, and the classic Kussmaul breathing, which are very rapid, extremely deep breath without dyspnea. And when I'm looking at that Kussmaul breathing, very classic of a ketoacidosis type of question. Basically, the respiratory center is trying to do whatever they can, wondering how am I going to get rid of that lower pH. The treatment is to immediately place that patient in the insulin world. And as we give insulin, let's not forget to give the glucose with it, otherwise we could have a fatal hypoglycemia, which would not be that good for CNS, wouldn't it? And then fluid and electrolyte replacement with particular care to the regulation of potassium is quite necessary. Remember that insulin drives potassium into muscle, so that even though there might be a hyperkalemia look because of the acidosis, you may have to administer potassium at the same time so as not to get a hypokalemia in managing DKA.